Good morning, everyone. I'm so sorry. I was just looking up, making sure that everything is in place. I'm Nasreen Alfaris. I'll be chairing the session today. It's going to be a very exciting session today about obesity medicine medications, when to use them either before, after, in combination with a surgery. Today I have my wonderful co-chairs, Dr. John Dixon and Dr. Rinki Murphy, and I'll hand over the mic to them to introduce themselves.
Oh, sorry. I'm John Dixon. Many of you know me. I've been working in the obesity space for a long time, and I'm very excited that we're here and we're able to talk about surgery, we're able to talk about the new drugs that are coming along, and I'm really looking forward to talking, but also hearing the other groups in this session.
Likewise. Kia ora koutou from warm New Zealand greetings from Rinki Murphy. I'm a professor in the Department of Medicine in the University of Auckland, and as an endocrinologist I've set up a weight management service in Counties Manukau. Some of you may not have as much access to the medications as we'd like, and I'll empathise with you, but really looking forward to a stunning discussion and case presentations.
It's coming, isn't it? They don't have it now, but it's definitely coming. Everybody
Absolutely.
will have, I promise you. That there's a lot in the pipelines and on top of the things that we have right now. So we are going to start our session today with Dr. Samantha Hawking, who is from the University of Sydney. She's going to be talking about indication, efficacy, and safety of the new anti-obesity medications. We're also going to have a brief Q&A right after she's done with her talks because she has another session to catch. And please, Samantha, start.
So thanks very much for the opportunity to speak today, and I apologise in advance to this other speakers in this session because I've been rostered on in another room at the same time. So I'm not leaving because I don't respect you, it's because I've got a clash, so I apologise for that. These are my disclosures, and relevant to this presentation I have worked with the pharmaceutical companies that make anti-obesity pharmacotherapies that we use in Australia. So I've been tasked with very briefly to talk about the indications for the new anti-obesity medications, and then looking at semaglutide 2.4 milligrams and tirzepatide 5, 10 and 15 milligrams for the treatment of obesity, and then their safety profiles. So in terms of the pharmacotherapy, when should we be using pharmacotherapy? And following on from the session this morning, I think it's probably pretty clear that we should be using pharmacotherapy in people with overweight or obesity when obesity-related complications are present. Now, ideally, we would like to be able to treat everybody with obesity, but probably at this point in time, we just do not have access to enough medications to treat everybody, and so limiting it to those people with obesity-related complications may be where we're best using these pharmacotherapies. Now, to some extent, that is in keeping with obesity as a chronic disease, because when we think about other chronic diseases, we do treat chronic diseases to prevent the development of their complications. So hypertension is a really good example of that. But I'm an endocrinologist, and if you put on the hat of type 2 diabetes, we actually treat type 2 diabetes to prevent the complications of developing type 2 diabetes. We do not wait until someone has retinopathy or neuropathy or kidney disease before we start to lower their blood glucose. So hopefully we will get to a time when we can treat obesity before people get complications, but I think that may be where we are at the moment. In terms of choosing anti-obesity pharmacotherapy then, if we're really talking about treating people with obesity-related complications to reduce those complications, then we do need to be thinking about pharmacotherapies and treatments that achieve enough weight loss to actually have an impact on those complications. And it really busts the myth that a 5% weight loss target is the target for everybody. I think we're now well and truly beyond that. And we certainly now have highly effective pharmacotherapies where we can be seeing mean weight loss in excess of 10% body weight reduction. So if people have complications where that degree of body weight reduction is required, we really need to be starting with that highly effective anti-obesity pharmacotherapy. So that, I hope, covers the indication for these medications. If we then turn our attention to the medications, I'm going to focus on the studies that were done in the population with overweight and obesity with pre-diabetes but without type 2 diabetes for both of the medications. Firstly, once weekly semaglutide 2.4 milligrams for adults with overweight or obesity but without type 2 diabetes, or the STEP 1 clinical trial. Now, this trial was published some years ago, so you're probably all very familiar with it. But just to walk you through it once again, this was an adult population with a BMI greater than 27 with more than one obesity-related comorbidity, or a population with a BMI over 30 who could not have diabetes but could have pre-diabetes, who were randomised 2-to-1 to semaglutide with the usual dose escalation monthly up to a 2.4 milligram weekly dose, and they were continued on the 2.4 milligram weekly dose for 1 year. The primary outcome was a weight loss outcome, but there were very important secondary outcomes which included improvements in health. And I think that's really important. There's no point getting just adiposity reduction without improvements in health outcomes. So I'm going to present both the weight loss and the improvement in health outcomes. So if we look at the weight loss curves and then the bar charts here, I'm showing you two different results. In the darker bar is the treatment policy estimand. That's best thought about as the intention to treat population. So this is the population who were prescribed the drug and the result that they achieved, irrespective of whether they remained on the medication throughout the duration of the trial. In the lighter bar is the on-treatment data, the trial product estimand. So this is the group of patients who were prescribed the medication and remained on it through the duration of the trial. And if we look at that group, what we can see is a mean 16.9% body weight reduction by the end of the trial. But of course, the mean hides some of the detail. So presented here are the categorical weight loss outcomes. So focusing on the graphic on the right, which is that on-treatment group, we can now see that there were most of the population actually were responders, defined as achieving a more than 5% weight loss. And this is in fact over 9 in 10 individuals. Very high categorical levels of weight loss were achieved. More than 15% body weight loss in 1 in 2 participants, and more than 20% body weight loss in 1/3 of the clinical trial population. And this is why we're now saying these medications are beginning to rival bariatric surgery, where we're seeing mean weight losses of, say, 20 to 25 to 30% at 1 year. What's more important, of course, is the improvement in health outcomes that was associated with this weight loss. So we're seeing very large reductions in waist circumference, an indicator of visceral adiposity, which we know is associated with cardiometabolic disease. We're seeing reductions in systolic and diastolic blood pressure, improvements in glycemia, even in this population that did not have type 2 diabetes but could have pre-diabetes. Very important for our patients, improvements in health-related quality of life, and reductions in CRP as a marker of systemic inflammation. In addition, there were improvements in fasting lipids in this STEP 1 clinical trial. Not unexpectedly, there was a large reduction in serum triglyceride levels. That's what we'd expect to see with those large reductions in waist circumference, but we're also seeing improvements in total cholesterol, LDL cholesterol, and HDL cholesterol, with HDL obviously going up, being a protective lipid. Now, people always ask about the weight loss. Is there a loss of lean mass as well as a loss of fat mass? And of course there is. Whenever you lose weight, you will lose lean mass and fat mass. But what's really important is you proportionately lose more fat mass than lean mass. And in actual fact, you may actually lose fat from muscle, meaning that even though there's less muscle, the muscle that remains is more functional. So definitely improvements in body composition. What about durability? So I'm just showing you one additional study here. This was the STEP 5 trial. The main reason for showing this curve is that the curve remains flat with ongoing use of medication. So if you stay on the pharmacotherapy, if you remain on the 2.4 milligram dose, you continue to maintain the weight loss at least out to 104 weeks. And obviously we need longer term data than this, and that will obviously come as as we get real world evidence from using these medications in our clinical practice. So turning our attention to safety, because of the limitations in time, I'm not going to go through every adverse event that was reported in this trial, but to let you know that out of those that occurred in more than 10% of the population, the commonest were the gastrointestinal side effects. Now, we know about this from using these medications in type 2 diabetes. It's important to warn patients when we're prescribing these therapies of this very common and known side effect. In clinical practice, we can, of course, slow the dose escalation if there are issues with the GIT tolerability. The commonest is nausea, but diarrhoea, vomiting, and constipation can also occur. It's important to note that most of these side effects are mild to moderate in severity, and they tend to occur during the dose escalation period and then wane once people are on a sustained dose, and they do improve with time. So now we'll move on to the tirzepatide trial, the SURMOUNT-1 trial. This was a very similar study to the STEP 1 clinical trial that I have already shown you. Again, it has been published some years ago, but just to remind you, this was a similar population, so a population of adults with a BMI greater than or equal to 27 with at least one weight-related comorbidity, or a BMI greater than or equal to 30. You could not have type 2 diabetes or type 1 diabetes to be in this study. There were 3 doses of tirzepatide studied, a 5, a 10, and a 15 milligram dose. And there was the usual monthly dose escalation. Because the 15 milligram dose takes a long time to get there, increasing by 2.5 milligrams every month, there was a 20-week dose escalation for the 15 milligram group. And then participants remained on the medication for 1 year, meaning that the outcomes were reported at 72 weeks. So once again, I'm showing you 2 different sets of data. On the left is the intention to treatment type data. So this is the data irrespective of whether you remained on the medication. On the right are those who remained on the intended dose of the pharmacotherapy for the duration of the trial. So let's look at the data on the right. So what we can see is with the 5 milligram dose, we're achieving a 16% body weight reduction. With the 10 milligram dose, 21.4% body weight reduction. And with the 15 milligram dose, 22.5% body weight reduction. Again, looking at the categorical weight loss to tease out that mean data, let's focus again on the graph on the right, those who took the medication as it was to be intended. Impressively, we're now seeing up to 25% body weight reduction. We're seeing a very high responder rate, 96% of those who were treated with the 15 milligram dose losing more than 5% of their body weight. And very impressively, we're seeing 2 in 5 participants achieving a weight loss in excess of 25% body weight reduction. The weight loss with this agent is very impressive, but it's the health outcomes that we're interested in. An 18.5% reduction in waist circumference, impressive improvements in systolic and diastolic blood pressure, improvements in fasting insulin and dysglycemia, again, even in a population without type 2 diabetes, very impressive reductions in serum triglycerides and improvements in HDL, and obviously the very important one for our patients, improved in physical function and quality of life. Very similar to semaglutide 2.4 milligrams, the commonest adverse events with tirzepatide were nausea and vomiting and diarrhoea over time. And again, mild to moderate in severity, again, mostly during the dose escalation period. Again, very important to warn patients of this particular adverse event and potentially to slow the dose escalation in clinical practice to improve tolerability. So, in summary, semaglutide and tirzepatide in people with obesity result in very significant and very clinically meaningful reductions in body weight, achieving body weight reductions that should help reverse or treat the complications of obesity, improvement in cardiovascular risk factors, very importantly, improvements in quality of life. The most common adverse events with any incretin therapy are gastrointestinal in nature, mostly mild to moderate in severity, and tend to occur early during the dose escalation. And I hope I've left enough time for a few questions.
We're going to have time for a couple of questions, I think, just because you're going in, then we'll keep all the other questions at the very end. So if anyone has any questions for Dr. Samantha?
Thank you, Samantha. Tony from Sydney. Samantha, we're very lucky in Australia. We have both medications available. Yes, you're right, tirzepatide, as it here is not indicated for obesity, not quite yet in
Not
Australia.
yet.
Many of us are using it off-label. We're very fortunate. How do you decide, in terms of the patient in front of you, whether or not you're going to treat them with semaglutide or whether or not you're going to treat them with tirzepatide? We've seen the weight loss data. Is there any difference in health outcomes, particularly to make us decide on one over the other?
Yeah, thanks for that question, Tony. So obviously the first answer to that is there hasn't been a head-to-head clinical trial. So in that way, there's no head-to-head clinical data. So then what I'm saying is really my own opinion, evidence not based. So I think it comes down to a conversation with the patient. I mean, at the moment in Australia, it's just changed, but we did have different delivery devices, for example, between the two medications that some people may have preferred over others. I think it comes down to discussing the medications, discussing the side effects, discussing the cost, because they are differently priced, and then coming to a mutually agreed decision. Importantly, pointing out that, they've got high responder rates, but some people don't have as much weight loss response, and then maybe you would try the other agent if the first medication didn't work as well as you wanted or didn't suit them. So I think we're really, really lucky that we have choice, and it just comes down to that conversation between you and the patient to personalise the therapy. Happy?
Good answer. We're happy.
Thank you so
Okay,
much.
thank you.
So welcome, Nasreen. You don't need any introduction, so
Oh, thank you
please
so
dive
much.
in. Thank you.
Okay, so I am going to, there we go, is that, I still don't have my talk, okay, there we go. Yeah, so I'm going to give a brief talk on who may benefit from obesity medicine management, obesity medication, management medication. I used to call them anti-obesity medication. It's really very, very hard to me to shift that thought process before surgery. And this is a very, very tricky topic to speak about. This is my brief introduction. I'm an endocrinologist. I'm also obesity medicine. I'm the program director of the Obesity Medicine Fellowship. Here in IFSO, I wear the hat of being the co-chair of the guidelines committee. So hopefully you'll see more guidelines on what to do with these meds with surgery, as opposed to the guidelines that we have out right now in the world that talks about individuals who are basically surgery naive. Okay, so these are my disclosures, and I'm going to start with the rationale supporting the use of anti-obesity medication in the preoperative setting. So there are two reasons, and today I'm not going to talk about complications, because to control your blood sugar or to control the obstructive sleep apnea prior to going to surgery, that's a different topic for another day. I'm just going to talk about those individuals who do not have the complications. Do they really need that anti-obesity medication prior to surgery? So the first rationale is reduction of preoperative risk, and the second one is increased proportion of those achieving weight loss goals and complication resolutions after surgery. And I'm going to go through the data that supports each and every one of them, and just a heads up, there's really no consensus on what to do. So I'm just going to put in the data here, and then this brain bank can think about what to do with patients. So I'm going to start with the biggest. The MBS Equip is a very, very big registry in the US, and they look at different patients. And this was a registry of about 500,000 patients in the MBS Equip. They looked at these individuals, and they wanted to see if preoperative body weight loss had any effect on 30-day mortality. And what they found that if you lost up to 5% of your weight, you had a reduction in 24% of mortality. Up to 9.9, there was a 31%, and 10% was a 42%. So it seemed like in this observational study, there was some benefit that was seen in 30-day mortality. But, food for thought, I'm going to show you other data as well. Again, this is another big registry that looked, again, more than 500,000 patients, and looked at their mortality and looked at the risk of leak that happens if those individuals did lose weight prior to metabolic surgery. And just put in mind that this did not look specifically on individuals that were on anti-obesity medications. It was all weight losers, regardless of the fact. So when compared to individuals who did not lose any weight, anyone that lost more than 10% of their total body weight had a 30% decrease in odds of leak and had a 40% decrease in odds of mortality. So again, another thing that may point out that probably some weight losses in these individuals prior to metabolic surgery may be beneficial. How about predicting bariatric surgery post-operative weight loss? How about predicting complications? If you lose weight before surgery, is this going to result in more weight loss overall? Is this a good thing, or is it not? Doesn't make a difference? And this was actually again looked at, and you can see here the study. Unfortunately, it did not look at total body weight losses, but it looked at excess body weight loss, and they looked at basically if you lost less than 10% of excess body weight loss versus more than 10% in both in patients who underwent both Roux-en-Y gastric bypass surgery or sleeve gastrectomies. And what they saw that really there was no difference in complications post-operatively in that immediate period post-operatively. There was no difference in length of stay. There was no difference in ICU admissions for those who lost that weight. But mind you, this was excess body weight loss. It was only 10%. So, I mean, how significant is that? There was another consensus that looked at is waiting longer before bariatric surgery more effective? Should we do this? Should we have our patients come in, wait, and put them on something to lose medication, whatever that intervention is? And again, I'm not talking right now about anti-obesity medications per se. The conclusion was that really longer preoperative wait times did not result in any improvements in weight loss or reduced adverse events. And the recommendations from that paper was to actually individualize your treatments and look at each person in an individual way and see if that patient really needs the weight loss versus not. So not really much out of that paper. Again, but everybody made a very important point here, was that really mandating weight loss before surgery was not the right thing to do. And this was published again back in 2016 as saying that there's really no level 1 data that shows that if you were to put any patient on a weight loss regimen prior to surgery, on a mandated weight loss regimen, that would be a good thing. And that practice is actually discriminatory and ends up putting those patients into probably more risk because you're making them live with a chronic disease for a longer time. In 2022, the newer guidelines that were done in combination with ASMBS, IFSO and ASMBS, made a very strong point as well to mentioning that and said, again, there is no really data to support the practice of insurance-mandated preoperative weight loss. This practice is understood to be discriminatory again. It contributes to patient attrition. There's unnecessary delay. But mind you, although these guidelines were published in 2022, there was no mention at all of anti-obesity medications, although at that time we did have a good number of anti-obesity medications that were out there and that were FDA approved. So again, a very big question mark. So let's look at individual medications. I'm going to start with orlistat. I'm really going to fly through the orlistat data because orlistat is not really a good anti-obesity medication, but there is some data looking at its weight loss before surgery. And this was a study that looked at individuals with a BMI of about 47, and what they found that their total body weight losses on the intervention was about 5% as compared to controls, and really patients didn't feel any difference, and there wasn't really a lot of weight loss that happened. It was only 5%. So is it worth it putting someone on a medication and waiting for a few months to lose 5% rather than go for surgery? Very questionable. Again, another study looked at this, and the only positive thing that they found with orlistat, that it did reduce OR time by 22 minutes, but there was no difference in 30-day mortality. There was no difference in weight loss at 24 months. But again, there was really not much of weight loss. The weight loss in this trial was about 5%. And again, these are all observational trials. These are not randomized control trials, so no level 1 data. This was a poster that was presented looking at low-dose phentermine, which is Lumera, which is an 8 milligram dose phentermine that's given 3 times a day, and they basically gave it to individuals that were going for metabolic surgery. And what they found was in the treatment group, the average BMI was 49, the average BMI in the control group was 47. So patients with pretty severe obesity that were on Lamera, they put them on Lamera for about 14 weeks, so about 3 months. And what they saw is that the total body weight loss was about 4.7% in those individuals that were on the drug versus those who were not on the drug, 3.6%. Again, not very impressive. This is the most interesting study of them all, and I wish this could be done again. They looked at phentermine topiramate weight use in those individuals with severe obesity. So these are the individuals where your surgeons will come and ask you to put them on anti-obesity medication. Now, what's interesting, they used phentermine topiramate, which is a pretty good drug. Placebo-subtracted weight loss with phentermine topiramate is about 9%. But the thing with this study is they put these individuals on these anti-obesity medications prior to surgery and continued through after surgery. So it's really hard to comb out the effect of pre and post, but we have the data. Their initial BMIs, as I said, were large. If you look at the comparison group, which was sleeve gastrectomies on their own, obviously the people on phentermine topiramate plus the sleeve gastrectomy ended up losing way more weight preoperatively than those who were only on the sleeve gastrectomy group. Operative time, length of stay, 30-day complication rate, no difference at all. BMI changes were significantly reduced at 6 months, and again, they kept that at 24 months. But the question is that because of the preoperative weight loss, or is that because of the continued medication? We don't know. We really don't know. So again, a very, very interesting study, food for thought, and food for thought of how we manage our patients. Are we supposed to actually do this? Are we supposed to continue on medications? GLP-1 receptor agonist, this is a study looking at liraglutide compared to a balloon with sleeve gastrectomy. Individuals on balloons did better, again in patients with severe obesity, BMIs of more than 55, and complications. As I said, people on balloon did better than the people on liraglutide. Actually, the liraglutide group didn't fare so well. Liraglutide 3 milligram, again, remission of prediabetes. Yes, the prediabetes got better, but if you look at the weight losses, again, at 6 months, they looked at weight losses at 6 months. Here in the light purple and the dark purple was at 12 months. And you can see, you have the responders. Most people lost 5% or more, less lost 15, but really, again, no differences other than the prediabetes remission that happened. More in the treatment group, which was at 92%, which we know the liraglutide is a pretty good drug for blood sugars. 3 milligram liraglutide versus semaglutide, 1 milligram for preoperative use. Again, they stratified these patients into class 1, class 2, class 1, class 2, and then above 40, and then again above 45, so severe obesity. And I'm going to show you by classification. And here, just to walk you through it, everybody in green is the class 2 obesity between 35 and 39, and then class 3 obesity between 40 and 45 is the one in orange, and then more than 45 is the one in blue. And you can see here we spread from the super responders, and so there was a percentage, especially in the that lost more than 20%. But it seems that the group that benefited the most were the between 40 and 45. Why? I don't have an answer to that. This is just a schematic showing you the anti-obesity medications that are currently approved and that actually FDA approved and that are in the market: the phentermine topiramate, the naltrexone, bupropion, the liraglutide 3 milligrams, semaglutide, and tirzepatide. Tirzepatide being the most effective, and the SURMOUNT-4 placebo-subtracted was about 21%. So, in conclusion, everything that I've told you, what does that tell us? And I did warn you in the very beginning because we really don't know. Currently, there's really insufficient high-quality data to recommend that everybody with a high BMI or who needs to go to surgery needs to be on anti-obesity medication. Do we need to produce that data? Yes, we do, because everything we have so far is observational data. But with individuals with severe obesity, those individuals with BMIs of 50 and above, there's really some data that may show that there's a benefit, but we shouldn't mandate routine preoperative anti-obesity medication. We should take it patient by patient. And the future research is really needed to explore what are the benefits of this use. Another food for thought that's really, really important that we have to think about is that the anti-obesity medications in the pipelines are just so powerful that it's not going to be the thought of preoperative anti-obesity medication. It probably is going to be, do you want to go for surgery versus should I just start on pharmacotherapy, because you probably will lose 20%. And then the other thing that you have to put in mind is these GLP-1s have very long titration periods. So to get to the full dose, it may take up to 6 months. And do we really want our patients to be on a waiting list for 6 months? And I'll end with that, and thank you so much to listening to me.
Thanks, Nasreen. I'd like now to introduce Kwong Wei. Kwong Wei is an endocrinologist, obesity specialist from Singapore. She's worked in the area for quite a long while, has experience with surgery and some of the new drugs, and she's going to talk about the use of these drugs, obesity management medications, following bariatric metabolic surgery.
Thanks. Thank you, John. So my focus will be on obesity management medications, it's a new term that we're going to use with IFSO, and it'll be after surgery, and with particular focus for when. These are my disclosures. So I'm going to cover, with relation to this topic, indications for use, existing data, and reports. In fact, with the new drugs that are emerging, there's a lot of discussion about what to use when, as Nasreen has pointed out. So and we're going to just discuss some of the data that we've discussed with the consensus recently and the practical considerations. So the common indications are usually insufficient or inadequate weight loss, now called suboptimal initial clinical response by IFSO, or weight regain, and more often not, it is weight regain. And these are the definitions that has been come up with the IFSO consensus, both with quantums or in relation to obesity complications that were the initial indication for surgery. So therefore, the indications for OMM could be just control of obesity complications or its comorbidities. So in terms of existing data, because of all this evolution and uncertainty, IFSO called for and conducted actually a consensus on the role of OMM in the context of metabolic and bariatric surgery. You can get from this QR code the write-up, or if you prefer paper, there's this bariatric news that's available at the IFSO stand. So basically, there's not a lot of data. We have about 20 studies, most of which are retrospective, just a few prospective, and only 6 RCTs, of which 4 are related to weight and 2 are for type 2 diabetes. So this is not for you to memorize, but just to illustrate the complicated data or the lack of data for us to sift through to come to a conclusion. The numbers are variable, mostly a handful. The exposure is of variable duration, different types of medications, different types of surgery. So I took this study of 319 patients to illustrate some of the challenges to tease through the data. So this is from MGH and Weill Cornell. They took 319 patients, 80% of whom had Roux-en-Y gastric bypass or received weight loss medications, most for recurrent weight gain, and they had at least 12 months of follow-up after the OMM was started. On the whole, it took 52 months from the time of surgery before they were started on any OMM. Now, these are this is the list of medications they were exposed to. Imagine trying to tease through the data from there. Some were from, and you can notice probably lorcaserin and sibutramine have been taken off the market. Exenatide was the only GLP-1 used at that time and was for type 2 diabetes. Anyway, just to summarize it, OMM use after MBS for whether it's recurrent weight gain or insufficient weight loss has some efficacy in weight loss with about 7.8% of weight loss, with RIGB patients losing more weight compared to sleeve gastrectomy. On the whole, topiramate was the most frequently used and associated with more weight loss. Patients tend to have combination pharmacotherapy, which is, the way of life and how we treat our patients. Average number was 2. Now, although most patients was treated because they regained the weight, the patients who were started on the OMM when they reached a plateau saw greater cumulative weight loss at 32.3% as opposed to about 27% with people with recurrent weight gain. So these are the 7 studies related to liraglutide, the most single drug studied. I would say these are all retrospective, just a few are prospective. Most are 3 milligram dosage. Just to summarize, they were used for 24 weeks up to 24 months, mostly about 6 months. The weight loss seen, the amount of weight loss seen with and without surgery was no difference, and this was compared to the scale study, which looked at liraglutide 3 milligrams in people without diabetes. Now, whether it was any types of surgery, the weight loss amount was still the same. Mean weight losses can be up to 6 to 8%, whether it's 24 weeks or up to about 12 months. And there were no predictors of weight loss with the use of liraglutide. So this table sort of summarizes some of the weight loss data from the RCTs. It's not as updated as the one Nasreen showed you, but in summary, you see phentermine, you get 4 to 6 kgs, and then when you combine that with topiramate, up to 10.5%, and with liraglutide, is 6 to 8%. Now, this is not head-to-head comparison, but with weight loss with OMM after surgery, you can see the amount of weight loss, the incremental weight loss we call it, is about the same even without surgery. In fact, there is a suggestion that maybe slightly more weight loss, but again, this is not head-to-head comparison. Now, semaglutide and tirzepatide are very new, so we barely have any data. This is a report from the UAE looking at 115 patients who had RWG after sleeve gastrectomy. And you can see at 6 months, sorry, it's a bit blurred there, but 10.3% weight loss there. If we sort of extrapolate the step 1 study at 6 months, 24 weeks, it's about there. We could see same amount of weight loss. And tirzepatide, extrapolating it from the SURMOUNT one, you can see the weight loss with after surgery is on par with patients without surgery. So the only RCT we have, sorry, not the only RCT, but this is the RCT with liraglutide with insufficient weight loss of 20% in 1 year. And you can see at 24 weeks, you see about 9% weight loss with liraglutide, quite similar to what we see in the scale studies with those categorical weight loss. So I think I want to close up in the next few seconds on practical considerations. We really don't have enough data, right? So I think we sort of have to make our own conclusions. On average, there are about 25% of patients who would experience some kind of either insufficient weight loss or recurrent weight gain. And this tends to happen 1 to 2 years post-surgery, and by 5 years, most patients would have manifested their weight regain in that sense. But when this database from the US looked at the 59,000 patients who had undergone bariatric surgery, they found that only 8,000 of patients were using AOM, and that's about 0.2 to 2.9%. So that points to our real-world practice of treatment inertia, whether it's patient or physician, right? In the studies that I've sort of alluded to, it took about 5 to 8 years before they really were started on any medications. And usually it's for recurrent weight gain, which is we're more reactive rather than being proactive, right? So patients tend to drag out with that weight. Their eating habits have been set. It's harder to make them lose the weight or change their habits, and it's higher weight we start off with. But on the other hand, do we start early? There's no data. The RCT by Thakur showed that if we started early, within 6 weeks post-sleeve, the weight loss was not any better. So I think just to close up, I think real-world practice is needed. This is by Caroline Apovin's group, where they said follow up patients closely. If you regain weight quicker, evaluate and start pharmacotherapy early. In Singapore, we have this weight trajectory charts. We found that at 9 to 12 months is when patients reach a peak weight loss, and they may start to weight regain. We looked at ethnicity, types of surgery, gender, and we found that males, Chinese ethnicity, people with rear-wide gastric bypass had greater weight loss. Therefore, we've used this to be monitoring our patients more tightly, or even just warn them before surgery when weight regain may happen. So I think we need to ask ourselves, what are we treating? What is the target? As Samantha has alluded to, targets of treatment should not just be weight. We're treating a chronic, relapsing, progressive issue, right? And are we treating weight? We're treating obesity? Or are we treating the patient? Maybe the patient, all they want is to breathe better, to get off that CPAP and not have the insulin, right? So instead of being weight-focused, we need to be patient-focused. So I think these are my personal conclusions, because there's lack of data, lack of hard data on optimal timing. I think we need clinical common sense. We need to be proactive rather than reactive. We need to use what we have, patient factors such as rate regain, clinical parameters, and we should use things like presence and severity of complications rather than weight alone. In terms of choice of OMM, no difference with people who have not gone for surgery. Patient phenotype, cost, access, etc. should be our guidance. At the end of the day, I think we have a lot of unanswered questions: optimal timing, duration of use, combination treatment, new OMM. Hopefully time will be able to answer these. Before I end, I'd like to invite everybody to come to join us in Mumbai at the IFSO APC, and I thank you for your attention.
Thank you very much. We'll have questions at the end, so I'd like to invite Professor John Dixon, who is a world leader in this area, for an exciting talk. Thank you.
I'm going to talk about body composition and weight loss, and particularly with I was asked to talk about pharmacotherapy. It's probably one of the areas we know least about. Thank you. Yep, here we are. What's the impact of obesity management on management medications on body composition? Okay, so these are my conflicts, and there's some machines there that measure body composition. Now, it's important. We've got total body mass. We've got fat-free mass. This is two compartments: fat-free mass and fat mass. And fat-free mass is made up of muscle, skin, bone, organs, and of course, fat is made up of generally fat. So when you look at this, about half of your fat-free mass is muscle. So that's what you need to sort of get a handle on. When we look at, this is a hypothesis that was published only this year in diabetes care. And if you have a look there, the hypothesis is that with the use of a GLP-1 agonist, there will be a weight loss of 17%. There'll be the placebo won't get anything like that. If we look at the fat loss down the bottom there, we'll see fat loss, and then you stop the drug and you'll see the gain and you'll get better regain if you use. This is a hypothesis that if you use resistance training exercises. So the idea. Resistance exercises, non-resistance exercises, and this is hypothesis, not results. So this is what they expect: a lot of fat regain, but very little, fat-free mass regain. If you look at the other side, if you don't do resistance exercise, you'll actually lose fat-free mass, muscle, and the sad thing is you're not going to put it back on again. If you don't get it in early. So their hypothesis is that there's a problem. What's the flaw? Any of you thought of it? So they're hypothesizing that fat-free mass and fat mass change independently. Got nothing to do with one another. Do anyone agree with that? No. So what we see is that total energy expenditure and fat-free mass are extraordinarily closely linked. This is double-label water studies put together in a brilliant association. You see fat-free mass and you'll see the total energy expenditure. Fat-free mass drives total energy expenditure. If we look on the other side, though, total energy expenditure with age, it's pretty interesting, isn't it? Men, you'll see women and men, total energy expenditure, this is not resting, it is the same at 30 as it is at 60. Now, that last study hypothesised that, the loss of weight was going to generate, 10 years of loss of muscle. We don't lose muscle between, and this is men and women. Are you aware of that? Importantly. Now, if we actually look at body mass and age, we see something a little different. We see this slight rise throughout adulthood, and again, it tips off at around 60 and drops. It's really interesting data. If we have a look at fat-free mass, we can see that level again of energy expenditure. So we're seeing it related to that. Interestingly enough, of course, what we're not seeing is that muscle's being lost at that time. If we look at fat mass and we look at age, you can see that there's huge variations, and you see that rise of fat both in men and women from 30 through till 60, and then it drops after that. No peak for menopause, no peak for other things, it's just there. And then body percent fat, you can see the variability in women, men are much less fat, of course that's the biggest predictor of total body fat, percentage body fat, and the rise that happens throughout adult life. So do we really understand BMI and weight over time? So total energy expenditure and fat-free mass, we see here total energy expenditure and body mass index, and over here the fat-free mass and total energy expenditure. So it's really driven by fat-free mass, and we would like to think we could maintain our muscle as we lose weight. Now, if we look at if we look in the past at excessive loss of muscle, excessive loss of fat-free mass, there's a figure that's been used is 25%, and really most weight loss actually are better than that. So that's the concept is 25%. It's more than that, it's a problem. So this is some data from 275 European ethnicity people here in Melbourne, and you can see they're various. These were people coming along for all sorts of weight loss studies. Okay. If we look here at fat-free mass and fat mass, sorry, this is total fat mass and this is BMI. You can see that fat mass and total fat mass and BMI, you see, it's all right. This is fat mass, that's BMI. It's easy for me to see up there. You'll see that men and women have about the same percentage fat, the same amount of fat at increasing BMI, which is understandable. All right, it's not. It's slightly higher in women than men. But if we go on the other side and look at fat-free mass and increasing BMI, you'll see that men are on the bottom there. Women are on the bottom there, less fat-free mass, and men are on the top. And you'll see that they're also linear. And if we can correct for age, etc., we will find them even more linear. So when we expect to lose fat, we expect to drop down in a linear fashion in fat-free mass. Okay, so it's interesting. Now, how much do we expect? Well, this is the data from this study, and I'm only going to focus on the key factors, and that is in males, we expect to see about 41% of the loss of weight is going to be fat-free mass, of which some is going to be muscle and some organs and so forth. But just think of half of that. And in women, 33.9%. The reason why women are less is they've got less fat-free mass to start with, and their proportion is that way inclined. Now, when we put on weight, these are studies of people putting on weight, and in sedentary people, what the weight they put on is 60 to 70% fat. In other words, fat-free mass gain is 30 to 40%, exactly the same. So when we lose weight, we lose muscle. When we gain weight, we gain muscle, and it's in a nice proportion. So when we comes to, so this is what's expected. And I'm going to say that we don't know much about young age, old age, and ethnicity. We need a lot more work to be done. Now, in a review we did years ago, we looked at low-calorie diets and the loss of fat-free mass that was found in 15 studies, 17%. Low-calorie diets and exercise, 19%. Low-calorie diets and drugs, there were very few drug studies, and I'll show you the results in a minute. Very low-calorie diets and exercise, 16%. BPD, 15 studies, all right? 30%. Roux-y gastric bypass, 4 studies, 30%. And LAGB, 15 studies and 17%. Now, all of those are better off, almost all of those are better off than we'd expect. But those two bigger procedures, pushing more weight loss, approaching. Now, when we look at the drugs, we've got very little data, but data from liraglutide with a 6.3 total weight loss, 14% of that was fat-free mass. That's really good. If we look at bupropion and naltrexone bupropion, 8.2 kilograms lost, 22% lean body mass. These two drugs and these two studies, they're better than we would expect. People have more muscle than we would expect for the achieved BMI. If we go down the bottom, this is from the Chaston review that we did. The orlistat produced just 11% of lean body mass lost. Sibutramine, 31%, and sibutramine with low-calorie diet, 38%. So there's a problematic one there, isn't there? So now when we come to newer drugs, and this is, I suppose, what you're really interested in, and I think Sam might have showed you this, but if we have a look at semaglutide, you get 61% of fat mass and 39% loss of lean body mass. She said it was favourable because this was more than that. Can you see it there? But in fact, that's approaching what we'd expect men to lose, isn't it? Not women. And so that's a flag to me. That's the first drug. If we look at tirzepatide, on the other hand, 75-25, that's different. And I want, and it's interesting, semaglutide is quite different to what we saw with liraglutide. And we've got to get more information about these drugs. And there's a retretide, which is the triple hormone. You see 60 and 33. So there's a few drugs out there. There's a few drugs that we're concerned about. Sibutramine, it's off the market. Semaglutide, 39%, and retretide, producing 31%. Again, we're seeing that slightly higher than the gastric bypass and the BPD. So we need more information on GLP-1 agonists, especially those associated with greater weight loss. We need more information on the young, the elderly, and particularly people at risk of sarcopenia, and data from different interest groups, different groups. We have little or no information on drug effects on bone, but there is a hint that, again, liraglutide and semaglutide, with data published recently, have quite different effects on bone. So one type of drug having quite different effects on bone. We need a lot more information. Thank you.
Thank you so much. So thank you, John, for a great talk. And we're going to move on to Dr. Silvioletti, who's a nutritionist. She is the Integrated Health IFSO president currently. She is a researcher at the University of Brasilia in Brazil, and she's going to be giving us a talk on what is the impact of obesity medication on nutrition. Should we be concerned?
So, good morning, everyone. So I'm going to talk about what is the impact of obesity medication on nutrition, and should we be concerned. I'm glad to be here with these renowned speakers. I have no disclosures. As you know, medications are performing better. We have more than 15% of weight loss with the new generation of medications, and with this medication, improvements in obesity-associated complications are have been proved to be better. The main objective of my presentation is to discuss the impact of obesity management medication on nutrition, and I will focus in three main points. The possible nutritional deficiencies that may occur in terms of protein and micronutrients. I will talk about eating behaviors and also body composition, and I will focus on possible muscle mass loss. And it's easier for me to talk after Dr. Dixon because his speech was amazing. So for me to talk about that, I have to talk about a nutritionist has to do a complete nutritional assessment to evaluate these three main points. So a complete nutritional assessment has to have an assessment of possible nutrient deficits, And also we should evaluate nutrient intake, also nutrient-focused history, and also we should include physical assessment of body composition. Besides, it is challenging in people with obesity, we should include this in our evaluation. And with patients that are being treated with obesity medication, we should monitor treatment response with the assessment or the response with the medication that in the obesity medication escalation, it should be done monthly, but if patients are already accustomed with the medication, it can be done every 3 months. We should address gastrointestinal symptoms and also monitor for emergent and or worsening of mood disorders. In terms of nutritional deficiencies, the 3 main concerns are macronutrients, mainly protein intake. The second is in terms of micronutrients, diets that do not reach 1,200 calories per day. We should consider taking multivitamin because they do not reach adequate amount of vitamins and minerals. This is a clinical consensus. And we should assess nutritional status as well. In this population, even using obesity management medication or after metabolic and bariatric surgery using the obesity medication, they have potential risk of nutritional deficiencies because we know that there is a high prevalence of nutritional deficiencies pre and post metabolic and bariatric surgery. Obesity medication significantly will reduce food intake, and this is similar to metabolic and bariatric surgery, so the caloric reduction will be lower than 1,200 calories per day. We should consider vitamin and mineral supplementations with obesity management medication. With metabolic and bariatric surgery, this is a consensus. And checking for nutritional blood and correcting deficiencies before the use of obesity medicine medication is important. There is a high prevalence of deficiencies of iron. We should check ferritin, folate, vitamin B12, and vitamin D. This is the most important ones. Continuing nutritional deficiencies, the diet quality may remain poor after metabolic and bariatric surgery, so the same is likely to be true with obesity management medication. So I added 2 references for that. The first one is with metabolic and bariatric surgery, and the second with the anti-obesity medication. In terms of eating behaviors, obesity management medication has a very good side in terms of increasing the well-being. Patients will reduce their rewarding value with high energy dense food, reduce negative effects in terms of they will increase the satiety, so they will lose weight and decrease the stigma. The treatment will provide individuals with moments of reflection to examine their food intake, and they can focus on health living. However, we should, before prescribing or using obesity medication, screen for eating disorders. There will be a decrease in caloric intake with no effort on eating habits, so it can mask eating disorders. And also the impact of the medications can lead to unwanted consequences on eating behavior, so inappropriate food choice to provide adequate nutrient intake can happen. And also we should deal with some gastrointestinal side effects, and it can lead to decreased protein intake and micronutrient-rich food. So simple and easy orientation to improve eating habits is welcome. So focus on adequate protein intake and regular ingestion of fruits and vegetables can help patients to improve their habits. So in terms of body composition, the main concern is excessive muscle mass loss. We know that some muscle mass will be lost, but excessive muscle mass loss should be avoided. We should avoid the lack of information when we talk about body composition and patients before the use of medication or before the metabolic and bariatric surgery. We are trying to avoid sarcopenic obesity, that is a coexistence of obesity and sarcopenia, which is worse than just presenting one of the diseases, that both of them together make the patient even more, with a more serious disease. It can lead to a vicious cycle of weight regain, muscle loss, reduced mobility, higher risk of weight recurrence, risk of osteoporosis, frailty, and mortality. So we should avoid this disease. So what can we do to prevent excessive muscle mass loss? So we had a consensus on 2023, IFSO consensus, and so body composition evaluation is welcome. And also we should focus on adequate protein intake that should be higher than 60 grams per day for metabolic and bariatric surgery patients. Patients submitted to hypoabsorptive procedures should receive more than 100 grams per day. And the protein intake should be higher than 0.8 grams per kilogram of body weight, and strengthening exercises are also recommended. We have different papers on the consumption of consumption of protein or adequate consumption of protein with a very low calorie diet, sustaining that this will lead to a lower muscle mass loss. So this is different references, and also a recent paper highlighting that resistant exercises have a role in preventing sarcopenia-related conditions when we are using obesity management medication. So some advices on recommended intake. Some patients, with the use of the medications, will feel less thirsty. So advise them to take fluids and no caloric fluids, so no caloric beverage, more than 2 to 3 liters per day. Adequate protein intake is also advised. Micronutrients are also another concern. So treat pre-existing deficiencies and counseling adequate intake. Consider supplementation of multivitamin, calcium, and vitamin D if you are treating patients with obesity, and if you are treating patients with metabolic and bariatric surgery, there are some specific recommendations. And also focus on strengthening exercise to prevent excessive muscle mass loss. As a conclusion, some degree of muscle mass loss occurs in most of the scenarios. Evaluation of eating disorders should be done before the use of obesity medicine medications. Nutritional deficiencies, mainly micronutrients, may occur. And some take-home messages: multivitamins should be prescribed before the use of obesity medications. Screening for nutritional deficiencies and body composition evaluation should be done before the use of obesity medications. Adequate protein intake and physical activities may help to prevent excessive muscle loss. So thank you. I'm on time.
Thank you so much. So we'll move to wrapping it up with our last talk today by Dr. Georgia Regis, who is an adjunct associate lecturer at St. George and Sutherland Clinical School at the University of New South Wales. She's also a senior bariatric medical practitioner at St. George Private Hospital, Sydney, Australia. She'll be giving us a talk on how to navigate the problem of inconsistent access. So please, Georgia.
Thank you, everyone. I wasn't excited by the topic I was given because it puts me in a bit of a conflict, but I will disclose that on the next slide. So thank you to the speakers before me. Those of you that know me, I'm very much a hands-on clinician trying to bridge the gap between what the science tells us and how we're going to change clinical practice when we're back there next week. So these are my disclosures. I'm quite conflicted. I do consultancy work for anyone who's equally as committed as I am to obesity management. However, what was making me feel exceptionally conflicted was the last one, where I do some government advisory work. So I will be stressing that some of the things that I'll be talking about today are things that colleagues have been doing. I'm by no means endorsing off-label prescribing, especially if someone isn't particularly very well versed in this area. So on that note, I presume the topic was assigned because of the recent couple of years with these newer agents and our difficulty in accessing it, okay? And so I encourage you to go back to the olden days, like some of us have been here around, in this industry for some years now. What was life like before the newer incretin therapies were available? And there was life prior to Ozempic and Mounjaro and the like, okay? I know it's hard to believe. It's just like saying, what was life like before there was colour TV? It did exist. I was there. I remember it. It wasn't pleasant, but it did exist. So that said, in preparation for today's talk, I too was gobsmacked to actually see that we as clinicians have been treating or attempting to treat obesity since 1925 with what we now look at as thyroxine. How archaic, and maybe in the future years people will be looking at us today going, oh my gosh, is this what they were doing back in 2024? But the lessons that we have learned, despite the myriad of different medications that have been tried, and many have, as we've heard earlier, been removed from the market, what both patients and also clinicians seek are medications that are safe, effective, definitely tolerable, and also acceptable to the individual, because in the end, it's the individual person with a lived experience that needs to take the medication. And also the issue of access. And I know that we're going to have a significant discussion about this. But as Nasreen said at the beginning, even where you're working now, you may not have some of the medications that are going to be discussed. They are going to come, and there are so many exciting ones in the pipeline. So on that, which is a great segue to my next slide, it is not the focus of today's topic, but if time permits, we're more than happy to, unpack it if you'd like. We know that the reasons why we eat are many. Different cues. We have, as we can see here, different parts of the brain that are involved in our decisions to eat. And so it comes as no surprise, as you can see there on the right, that there are different medications that are tapping into these different parts of the brain, but also the fact that we know and we've learnt so much from bariatric surgery and how it works, that we now have pharma companies developing medications that are trying to mimic what bariatric surgery has achieved. So trying to bridge the gap, the neuroendocrine circuits, and to see how we can best help our patients. Now, given that I've got very limited time, I've decided to be very unique, because that's my middle name, and do my brief talk as a SWOT analysis, because that's what I found is useful when I've talked to government agencies who've only got a little bit of time and you've just got to get your key messages. So the medication shortage that you, I, and many of us still either have had or are experiencing. What are some of the strengths that have arisen out of this? Well, it's forced us to go back to what were we doing before we even had these incretin therapies. Well, what we do know does help is regular clinical touch points with our patients. During the COVID lockdown, this was really important, but even some of the data that we have preceded that. So whether you're having regular touch points in person, virtually, keeping patients engaged in this chronic disease management process is going to result in better health outcomes than if we let them fly in the wind and only come back when there's a problem. We also know, and this is evidence supported by the evidence, that patient support networks are also helpful. Now, I can anecdotally say that they can also be a hindrance, as we've seen on social media platforms where people are telling other patients you should do X number of clicks and, shake it here and a tap it there and then, all these kind of things. So as long as these patient support networks are being facilitated or monitored by a healthcare professional, then I think they do play a role. But let's put let's go straight to the point, because this is really what people want to know. So with these newer generation of obesity management medications, like Nasreen, I'm getting my head around the different terminology. If you do have access to them, however, it's in limited supply, what some individuals have done is to use the lowest effective dose, and that will help to control the patient's symptoms, and only increase the dose on an as-required basis. Now, I acknowledge, and I'll stress again, this is not what the product information monograph says on any of these medications. However, desperate times call for desperate measures. And the way I see it, I would rather have my patient on clinical therapy, even if it is a low dose that is improving their quality of life or at least preventing a relapse, rather than no therapy at all. And I'll explain my reasons shortly. So one option is if you do have that medication, but it's very ad hoc as to how often they're available, or there are other barriers, then lowest dose that's effective. And so, for example, as I've illustrated here, women who report premenstrual cravings, you could possibly increase it for that week or so, and then go back to the low maintenance dose. Alternatively, because patients are also doing it on their own, they're trying to be economical, making that one pen last, instead of it lasting a month, stretch it out for 2 months or so. And they might do the lowest dose, but they might say, I'm not going to step up the dose, but I know, and I'll just go with the theme of the menstrual cravings, because I have had them when I was younger and, in that part of my life, but also many of the women who are coming to seek surgery are women of, childbearing age, hence have menstrual cycles. So using that example, some ladies during the menstrual cycle may have increased intense cravings. So you might want to add a medication of that has a different mechanism of action that particularly taps into the reward centre or the mesolimbic part of the brain for that finite period of time. Or you may want to do the combination of both throughout the duration of treatment. But obviously we're going to be limited by availability and costs, okay? Another one is, just when you're thinking about how often I'm going to prescribe something is, what is the half-life of the medication? And so when do I think I could potentially advise the patient to stretch it out? So, for example, the weekly injectables have a half-life of about a week. So in theory, if the patient wanted to, they could take it every second week during a time of incredible shortage, even though it's against what the PI says. Now, different concept. Let's not forget that the medications that we have and still have prior to these new injectables are still safe, effective, and available some countries very readily available, some to a degree. But either way, we shouldn't be dismissive, because I'm reiterating the point. Treating a patient is more important than no treatment at all, and you can do that combination again. But what I also wanted to bring to your attention, and it has been touched on earlier, is we know that combination therapy works. So what about very low energy diets? They are safe and they are effective, and the combination therapy is often additive with anti-obesity medication. So I appreciate some of these examples I'm giving you are no longer available, but we've seen it with sibutramine. Oops, what have I done? Oh, here we are. We've seen it with topiramate, and we've seen it with liraglutide. So it's an additive weight loss, but more importantly, improvement in the person's health and well-being. So we can't be dismissive of double-digit weight loss and health gains. Weaknesses, though, obviously the inequity in access. So even if, like it is now in Australia, we do have the weekly injectables available in Australia. However, they're very cost prohibitive. And so those who need it the most are the ones that are least likely to access it. Then we have the issue of people who report feeling desperate and anxious. I need to start to get more of it because I've only got one more pen in the fridge. I need to ring around, and patients were ringing around the whole country to try to access these because they have been convinced that the medications are helping, but they've got that fear of relapse. And then there's the issue of tachyphylaxis, and I'm hoping we might be able to unpack that during the question and answer time later on, where because of these shortages, patients who had an effective response to treatment, but then we didn't have medications for over a year, when they did go back on it, report that it's not as effective the second time around. Oh gosh, sorry, all right, what are the threats? So I've alluded to from a patient with a lived experience perspective, some are hoarding. Some are saying, why am I paying more for this particular medication because I'm living with obesity versus my colleague who has diabetes, so the perceived fat tax. Well, this is what we had in Australia. We'd have pharmacies who were importing some of the medications from overseas and charging 5 times the usual cost, which was really unethical, if you ask me. Then compounding chemists. I don't know if in your respective jurisdiction you have this issue. We had this issue, and finally, I think probably a bit too late, but that's just me, and it stays here, the government intervened and said, all right, this is getting out of hand. We don't know what they're compounding, especially if these medications are patented, and the responsibility lies with us who actually prescribe and sign the prescription. And then, yeah, I'm looking at the clock. And then there's the issue of, I don't know if you've had calls from the pharmacists who've said, oh, why don't you prescribe the patient the higher dose vial so they can do dosing from a vial which doesn't have a preservative in it. Once again, putting the onus of responsibility on us. So I've been asked to speed along, even though my timer says otherwise. That's right. So
I'm sorry, the timer is wrong.
The
I think
timer's not.
it's wrong. It's
It's
20
not.
minutes
okay.
for
Never
each
been right.
person.
Oh, sorry, I wasn't told.
not
Okay,
working.
I've
No,
got.
the timer's got.
That's fine. All right. So essentially, I suppose what I want to say. Sorry that I wasn't told when I came up that was wrong. So essentially, what I want to implore you as healthcare professionals like myself, remember the responsibility lies with us as healthcare professionals. We are the ones that sign the prescription. So feel free to hold your ground. Now, opportunities that have arisen. It's actually been great to see patients finally believe that they've got a disease, and that I know we can have a discussion based on this morning, but also that the medications work. So we're seeing them wanting to come for care and for treatment. It also gives us an opportunity to engage the multidisciplinary team to see what can we do. It also gives us an opportunity to reflect on our practices. Are we entering the correct information in our data, etc.? You know, I didn't know that the IDC had been updated to version 11. I was still on version 10. And then, like I said, I'm not going to go into in detail because then it would potentially appear as though I'm recommending off-label prescribing. But these are some of the things that people have done to try to bridge the gap. So either utilising medications that have been used in other health spaces or in other countries. But the key message is when we're dealing with a chronic disease such as obesity, if we have an action plan, we have them for diabetes and sick days, we have them for asthma exacerbations, then we can, to reiterate the point earlier, be proactive rather than reactive in managing our patients. And finally, it also gives us an opportunity to advocate for our patients, to talk to our government agencies and say our patients are demanding treatment. So my closing remarks are, we need to have a better understanding of the heterogeneity of obesity from both presentation right up to the response to treatment. And hopefully future research and development in obesity management will reflect that. But at the moment, and I've said this before, this is the patient's journey and we're the support group. And we need to treat the patient in front of us with whatever needs they have and with no judgment. And on that note, I will finish because I'm aware that we've overrun. Sorry.
Don't worry about it. Thank you so much, Georgia. This was very, very helpful. Thank you.